Hello again, and welcome back to Science of Medicine. Today I want to talk about the physics of motion and flow. This is widely applicable, particularly within the musculoskeletal system and also within the blood and lungs as it relates to laminar flow. So remember that we've talked about some of the physiology of skeletal muscle, but in order to have movement, I need to have several things happen from a physics standpoint. First is I need to have contraction of the muscle, and those muscles that shorten will then transmit the force to the bones through tendons, and there are ligaments that will connect bones to transmit those forces. I also have bursa, which protect the tendons as they slide over the bones. I'll have some type of a joint in which I can allow for movement, and those joints will have bones that will have cartilage at the end that will articulate with another bone that has cartilage inside a capsule that has synovial fluid, this very viscous proteoglycan that will hold on to water. I need to have control of this system, and I'm going to have control of the system from my neurologic system, and so I need to have my peripheral nerves that are going to do the control. I've got to have control within the reflex arc of the spinal cord as well as from the brain, and I need to have sensors to be able to detect where my muscles are and to have a fail-safe in case I try to rip those muscles. So to remind you, for skeletal muscle, that the contraction process starts with a nerve on a neuromuscular junction of a skeletal muscle. That neuron will release acetylcholine. It will diffuse across that small synapse and bind with a receptor that will open a sodium channel. The opening of that sodium channel will permit depolarization of the muscle as the sodium moves from outside the cell, where its concentration is higher, to inside the cell. I will then have that depolarization cause the sarcoplasmic reticulum to open up its calcium channels, and that will allow calcium to move from inside the sarcoplasmic reticulum to outside. Once outside in the cytosol, it will bind with troponin C, which is part of the troponin complex, which is blocking actin. Once the inhibitory part of troponin then moves out of that groove, myosin can then bind within the actin groove and pivot. And when it does that, it will walk one unit and cause it to actually shorten. Now I have pumps that will reset my sarcoplasmic reticulum by pumping calcium back inside, repolarize my muscles, and set the point back to where my resting membrane potential is at its normal state. And I have acetylcholinesterase, which will degrade the acetylcholine in the synapse. So if I look at the muscle on a small level, I look at these myofibrils, these muscle cells, I have a fairly extensive sarcoplasmic reticulum, which is present. I will have plenty of mitochondria to be able to provide energy for doing these processes, and I can adjust the relative amounts of some of these things, and I'll talk about that a little bit later. That'll be based on the training that I do. If I look at a small level, the myosin, which actually is then linking to or binding in actin filament, can then walk along and shorten this sarcomere, or this length of my actin filaments and myosin. And as that shortens all the way down the myofibril, the whole length of that myofibril will then shorten, and that will shorten the muscle, which is then going to be present in some portion on the body. Now, I can look at this under a microscope and actually see that sarcomere, this unit that is actually shortening, which combines both the myosin as well as the actin. And I could look at it with a light microscope and see the myofibrils, which are here stained in pink, the nuclei for those cells, which are peripherally located, to show that striated or skeletal muscle. Now, I mentioned that I can adjust the various amounts of certain constituents within the skeletal muscle, and we try to characterize these based on two poles. One would be a fast twitch muscle, the other a slow twitch muscle. Fast twitch muscles are your bulky muscles. Those are the ones that are used for very fast, powerful movements, such as jumping or doing some sort of fast activity like a shot put. In this case, I need to have lots and lots of muscle fibrils in parallel to be able to do whatever I'm trying to ask it to do. I have an extensive sarcoplastic reticulum that is going to release lots of calcium once I depolarize that muscle. But it comes at the expense of not being able to sustain that, because most people aren't jumping for 10 minutes straight up and down with all their might. So I don't have as many mitochondria, I don't have the glycolytic enzymes to run through the Krebs cycle to be able to supply these muscles for long periods of time. Slow twitch muscles, on the other hand, are smaller fibered. I'm looking for prolonged continuous activity. So I have a very extensive blood supply. I've got lots of mitochondria, myoglobin, glycolytic enzymes, so that I can actually make plenty of ATP to be able to run these. These are going to be muscles that would be promoted by long, continuous kinds of exercises such as running. Now there are several movements that skeletal muscle can actually do, and I'm going to talk about some of those and demonstrate them. But these movements are facilitated by the placement of muscles. So for example, if I look at my arm and my biceps muscle, which is located right here, that biceps muscle is connecting up here and also connecting across down here. So when I shorten that, it will cause a motion which is called flexion, which is a bending that will decrease the angle between the part of my hand as well as my shoulder. The opposite of that is extension, which is located on the back side, and I will actually increase that angle. So there are many different skeletal muscles that will allow for flexion and extension, and they're going to go across some sort of joint that will permit that motion. Now, I have the ability, if I apply a torque to a particular joint, to rotate it. I can either rotate it towards the center of my body or away from the center of my body. And I call those two motions internal and external rotation. So if I were to look at my shoulder joint has a ball for my humerus, which is the bone which is present in my arm, and it lies in a shallow cup-like bone that will allow for quite substantial movements. And so if I were to take and move that inside, so towards the center of my body, my shoulder would actually be experiencing that will internally rotate my shoulder. And you can actually feel the muscles that are necessary that actually go around to connect to be able to do that. They're your pectoralis muscles. Likewise, if I move it away using muscles that are on the back side, that will be called external rotation because it's moving away. Sometimes I will move a limb away from the center of the body or towards the center of the body. Those motions are called abduction and adduction. So if I were to look at, in this case, moving away from the center of the body, this would be called abduction or abduction, and adduction would be moving towards the center of the body. I also have the possibility of moving things in a direction towards my head, a superior direction, such as my shoulder. I can elevate my shoulders or I can depress them. And so elevation is one movement, as is depression. There are a few very specific movements which are present based upon certain domains. For example, my forearm has two bones. It has a bone that lies on the pinky side, which is the ulnar, and then it has one that lies also on the side closest to your thumb, which is called the radius. And I can move my wrist relative to those two bones using muscles. I could have one movement, one motion that would lead to my palm being up and another one leading to the palm being down. Palm up is supination, palm down is pronation. Similarly, for my ankle, I have the ability to do several motions. And so if I look at my ankle and I move it towards where my foot is, that is called a plantar flexion. And if I move it backwards, it is called a dorsiflexion. That's because the top part of my foot is called the dorsum and the bottom part, the plantar surface. I also have the possibility of moving it inwards towards the center of my body. This is an inversion, or externally everting it away from the midline. And so those are typical movements that skeletal muscle will make, and that facilitated by various placements. In order to move things such as rotations, I have to have the muscle attachment going around some joint that you're going to do so that it will apply a torque. Others can be, like for flexion extension, along the axis of that particular joint. So our muscles are placed in certain directions, as I mentioned to you before. So I have my biceps muscles, which will go across the elbow and connect up here towards my shoulder. The pectoralis, which was on my anterior chest, does wrap around so that I can do an internal rotation of my shoulder. Now, as you can imagine, each muscle is going to have a certain equilibrium, if you will, length, a resting length, where there's a certain overlap of actin and myosin. But I can overlap a maximum amount of actin and myosin to generate a maximum amount of force. Now, if I need to lift something, we all have the experience of going to lift something and we think it's much heavier than it actually is, and as soon as we lift it, we recognize that this is not the case. Or we think something is going to be much lighter than it is, and we go to lift it and it's much heavier. So I have to have a feedback mechanism that allows me to be able to recruit more muscle fibrils that are in parallel to be able to generate enough force to do whatever task that I've asked my body to do. And that's the way that I can actually then lift something much heavier than I think that it actually is. When I do contract my muscles, I have two types of contraction that I can consider. The first is what's called isotonic contraction. In that case, I will actually apply some load to the muscle and it will shorten, but remain the constant amount of force, iso, same, tonic force or tension. So in this case, I'm trying to make that muscle force or tension the same, I will then lead the movement. On the other hand, I could apply, I could try to contract and do it in an isometric fashion. In isometric fashion, tension is increasing, but I actually don't shorten the muscles. So for example, if I had an isometric contraction, I would be actually contracting the muscles, but the joint or whatever it was would not actually lead to movement because I'm simply applying a force. So if you had something lying in your hand and you were continuing to go ahead and hold that, and then some person would put more and more force on that by putting, let's say, more books or whatever you'd be holding on that, you would apply an isometric contraction. You would continue to recruit additional myofibrils as that weight would continue to require more force. Now, if you don't have any load, or if you go to pick up an object that is exceptionally, you think is exceptionally heavy that is not, it will quickly move, and that skeletal muscle contraction against no load decreases to zero. Otherwise, if you didn't have that capability, then you would be hitting yourself as you would start to contract, because you would contract it and it would just have no load, and so it would snap to whatever direction you were particularly contracting in. So we have these abilities within our body to adjust to what the demands are. Let's talk a little bit about the energetics. Now, muscle contraction requires ATP. It's providing energy for the calcium pumps and the sarcoplasmic reticulum, the sodium, potassium, ATPase pumps to maintain this position so that you can depolarize the muscle. But if you actually look at the amount of ATP that you have present, it's enough for about a second or two of full contraction. There is another molecule, phosphocreatine, that is a shuttle, if you will, an extra energy source that will regenerate ATP from ADP. It also has a high energy phosphate bond that can do that regeneration, and you've got about an 8-second supply of that in many of your skeletal muscles. Now, of course, ultimately, I'm going to have to break down glycogen, which is the polymer of glucose, so that it can undergo the Krebs cycle and generate ATP. But if you stop having ATP, your muscles will not be able to function, and they will remain in whatever position they happen to be at. For example, if you die, once you die, if you had been contracting a muscle, that muscle will remain contracted until about a day later it will start to liquefy. That's why that's the nature for what's called rigor mortis, when a person has died and that muscle will remain contracted. Now, I have to have a way of sensing about my muscles, and the muscle spindles are the sensors that are doing this. I do have another type of sensor, which I'll mention in just a few minutes, called the Golgi tendon organ, but its purpose is only to keep you from ripping the muscles apart. The muscle spindles are what do most of the heavy lifting, so to say. And these muscle spindles actually have nerve fibers that are embedded within the muscle, but don't have actin and myosin in their central portions. And so what happens is these neurons are firing at a certain rate, but when that muscle is contracting and shortening, the rate at which it's firing is changing. And it is that change in rate that is what you're actually using as a sensor to detect whether you're contracted or whether you're not. So this is important because there are certain things that we know will happen and you can predict them. For example, if you have a reflex which is called the myotactic reflex, and the myotactic reflex is when I stretch a muscle very quickly, then it will cause a reflex arc through my spinal cord to contract the skeletal muscles to oppose that particular motion. This is made use of, for example, if you strike the patellar tendon, which is the tendon that goes from your kneecap down to your tibia or the shin bone. When that happens, your leg will move up very quickly, and when it does that, it will then not continue to move up quickly, but it will actually be dampened. It's also the reason that you never ever recap needles, because as soon as you actually pull those needle hub across away from its cap, there'll be no load, and that will have a tendency as you pull it to go back towards there, and you'll stick yourself. So it's never something that you actually will do. If these systems are working correctly, then you won't have a jerkiness. You'll have a very fluid motion with regard to how you will contract your muscles. If there is a problem, then it can lead to jerkiness of motion or oscillations. We call some of these motions clonus, and I'll talk about that in a minute. Now, I mentioned that you do also have a sensor called the Golgi tendon organ. It also is present, but is not used most of the time, because what it does is, if you have tension that is detected that is going to rip apart your muscle fibrils, it inhibits that particular muscle group to basically make it so that you don't tear that muscle apart. It's used predominantly as a fail-safe to not damage yourself. Now, I mentioned this spinal cord reflex, and I want to talk a little bit about it. So if this is sort of a diagram of a person's knee, here's the kneecap, and there's a tendon that goes between the kneecap and the anterior shin of the tibia. If you were to strike it, there would be a muscle spindle that would be activated that will go back to the spinal cord, and it would synapse. It would synapse with a couple things. Number one, it would synapse with a motor neuron that would then be going out to the muscle group on top of the leg that would tend to say, okay, stop shortening this or stop contracting. One that goes to the back of the leg, which would oppose this knee movement that would go forward. And then also it would synapse to send a signal up to the brain so that it would know what's going on. But by the time that signal got down from the brain, this reflex arc would have already played out, because the distance in this arc is much less than it is going up the spinal cord to the brain and then back down. There are a few special circumstances that can come into play also with this. If for some reason the spinal cord is transected, there is an injury, damage, trauma that makes it so that the spinal cord is severed, then there's no signals that's going from higher to lower levels, and eventually those neurons cease functioning. There's no reflexes that will be present after that time. Sometimes if there's damage to the spinal cord or to the brain, things like stroke or cerebral palsy, this can lead to a decrease in the synaptic inhibition of the muscles, and so they are more excitable in terms of the muscle spindles, and you'll get increased tone as well as what's called spasticity, and that leads to a less fluid movement. And you may have seen this in people that have either cerebral palsy or who have had a stroke. We all have had the experience of a muscle spasm. So let's say we overexercise or we hurt ourselves and there's an irritating factor to that muscle. The pain will cause a spinal cord reflex contraction of the surrounding muscles to try to protect it from movement. When that happens over a sustained period of time, it will then release, causing a spasm. Many times people will have this experience with a blepharospasm, where somewhere above their eye or their eyebrow, it'll just start twitching. And that's an example of a muscle spasm. It's maintained that contraction for such a long time that it will release. I mentioned about joints, and one of the things that I have is certain joints that will allow for a fairly large range of motion, such as on my fingers. I will have two bones that will articulate with each other through this articular cartilage, which is shown here in gray. The chondrocytes, or the cells of this articular cartilage, will actually then release a component of proteoglycan, which will be contained in a capsule that will allow for lubrication. The lubrication will then have will be confined to this joint space. Sometimes this can be large. For example, in the knee, it can be up to about 10 milliliters. Other times it's fairly small, such as on the fingers. Remember that I have bones that will transverse this joint, and they will be protected with a bursa, or the sheathing, to allow for the frictional force to be less. And if I look at ligaments within this is ligaments within the knee, I have to maintain structural integrity. So in my knee, I have four ligaments that are protecting this joint. I have a ligament that connects from the front of the tibia to the back of the femur. I have a ligament that protects from the back of the tibia to the front of the femur. Those are the anterior and posterior cruciate ligaments, respectively. I also have a ligament that's on the outside, or the lateral side, of the femur and fibula, which is this small bone that's down on the side, as well as one that goes to the tibia, from the tibia to the femur. And those are called the medial, if it's on the inside, or the lateral collateral ligaments. And sometimes these can be torn through trauma, and those are leading to sprains. They're graded based on how many fibers kind of go ripped. If they're completely ripped, then that's a grade 3. If some, then it's a grade 1 or a grade 2. And we do have clinically tests that we can use to be able to determine which one of these or more are damaged. So let's talk a little bit about physics of movement. I can think about movement as occurring either as translation or rotation, or some combination of those. If I have a block and I'm moving it in a certain direction one way or another, in order for that block to remain at rest, then the sum of forces that act on it have to sum to 0. If the force going to the right is greater than the block will translate. This can be affected by a number of things, and we can use this kind of knowledge to be able to look at certain physics on joints. So if I have these little blocks that are nearly stacked on each other that represent the vertebral bodies in the lumbar spine, L1 through L5, there's a set of muscles called that run along the outside of the spine that actually are applying a force downward. Now that force has both a compressive effect, which is shown here, as well as a shear effect, which is shown here. So if that muscle or group makes an angle, like I've shown here in this A, the compressive force would be what? Well, hopefully you see that that's a cosine function because it's adjacent relative to this hypotenuse. And the shear force, being opposite, would be a sine function. Now, in contrast, for rotational equilibria, I have a point of pivoting. And that point of pivoting, in order for my body to not have a rotation about that point, has got to be at equilibrium, meaning that the moment arm times the force, the product of those two, has to equal the moment arm times the opposite force. For example, in my hip, I have a set of muscles that will tend to keep my pelvis level around some point. What I have is in my hip joint a femur, which has a ball, and the acetabulum, which is the socket. And that ball of the femur fits within the head of the acetabulum and provides for motion. But when I'm walking, I don't want my pelvis to tip up and back. I want to maintain equilibrium and a level pelvis. And so I have to exert certain force of muscles to be able to do that. But I weigh a certain amount. And so that's providing a counterforce downward. So those muscles that are keeping my pelvis level have got to actually keep that in a level fashion. So if I look at a balance point, typically what I would have is a distance between the acetabulum femoral head of about 16 centimeters and about 25 centimeters to my center of gravity. Angle of those muscles is about 70 degrees, so I can actually express that equilibrium condition as the moment arm times the torque equaling the moment arm times the torque downwards. If I calculate that, what I find is a force upwards that is 234 if I weigh about 150 pounds with those measurements, or the muscles going backwards exerting about 249 pounds of force. Now, let's use this as sort of an example also. If I actually remember that my spinal column is made up of cervical, thoracic, and lumbar, as well as the fused sacral. If I actually do a calculation for an average person, center of gravity is about 58%, which puts it in the lumbar region, generally around L4. This is an important consideration. A lot of times people will have lumbar back pain. So let's think about why that might actually be. So if I have a person who is lifting, remember when you were taught to lift, you were taught to lift in a translational fashion, going straight up, as opposed to a rotational fashion where you're bent over. So explain why this lifting as in A is better on your lower back than lifting like in B. So if you think about it, in A, you just have a translational movement. There's no torque being applied to that lumbar spine. On the other hand, I've got whatever I'm lifting, whatever my weight is, plus the weight of the top part of my body that is being acted upon on that lower portion of my back. And so if I have like a 50-pound object that I'm picking up and I'm an average sized person, that ends up putting about 300 pounds of force on my lower back, which is why that people, when they don't lift properly, will go to the doctor because they'll have back pain. All right, let's switch gears a little bit and talk about flow. Now, if I model flow as going through a tube, such as a blood vessel or an airway, I can think about a pressure drop over a resistance to flow. But we model this using Poiseuille's law in the body, at least as a first approximation. Poiseuille's law deals with laminar flow, which is what we'll assume both the air in our lungs and through our bronchial tubes, or the flow going into our fluid systems in the arteries is actually being described by. And so Poiseuille's law says that the flow through this is proportional to the fourth power of the radius, directly proportional to the pressure drop, as well as inversely proportional to the viscosity of the fluid and the length of the tube. This is a very, very important consideration. This tells me that the flow through either my bronchial tubes or through my blood vessels is most strongly dependent upon the radius of those vessels. Now, I do recognize that blood vessels, arteries will distend; they'll increase their radius with increasing pressure, and so I'm going to ignore that for when I'm talking more about this for a first approximation. But I recognize that this happens. Laminar flow is one particular type of flow that can be modeled much more accurate, much more simply, and does not apply in all conditions. But for a first approximation, when you're thinking about this, this is not a bad way of thinking about it. So let's do an example. So people that have asthma, a lot of times when they have an acute worsening of that or an exacerbation, will have inflammation in their bronchial tubes. And when that happens, it changes the diameter of those bronchial tubes. But we have patients clinically measure what's called a peak expiratory flow rate. It's a meter that they will breathe into, so they'll take a deep breath and then breathe out very, very quickly. And you can measure that. So suppose a person's peak expiratory flow rate decreases to 1/4 of the value when the patient is not having inflammation in their airways or an asthma exacerbation. What change in the bronchial radii is expected, assuming all other factors, pressure, viscosity, length, are equal? So we're going to go back to Poiseuille's law, and when we do that, we'll find that it's a 29% decrease. I want to walk you through this. So what's easiest, since these pressures and other variables as well as constants are going to be considered constant in this case, is I'm going to take a ratio of two flows. The flow when I'm having an asthma exacerbation, we'll call that Q2. I said that that was 1/4 of the value when it's not. So that means if Q1 is 1, then Q2 would be 0.25. You could choose whatever you wanted. You could have chosen, 3.7 and then taken 25% of it for Q2, but just easier to do it in terms of 1 and 0.25. You can't choose 0 for Q1, but outside of that, when you do that and you put the expression, you'll see that the pi and 8, the delta p, the eta, and the length all cancel out, and you're left with a ratio of these two radii. And so when I solve for that, taking the fourth root, it means that the ratio of the second radius when I'm having an asthma exacerbation compared to when I'm not is 0.71, which is a 29% decrease, R1 being 1. This is the ratio 0.71 to 1. And that's how you would actually do that. So I hope this has taught you some things about how physics is applied to the body, both in terms of motion as well as flow. And I'll see you soon, and we'll talk about bioelectricity.